Hello everyone, my name is Rochelle and I will talk about the use of amantadine in Parkinson's disease and other akinetic rigid syndromes. What is amantadine? Amantadine is a tricyclic synthetic amine with actions that are antiviral, anti-Parkinsonian, and anti-hyperalgesic. It was first developed as an antiviral agent for the treatment of influenza A and was coincidentally discovered in 1969 to relieve and treat symptoms in a patient with Parkinson's disease. There have been several clinical trials since then that have found the effectiveness of amantadine alone with a combination of other anti-Parkinson disease medications. The treatment of levodopa-induced motor fluctuations and dyskinesia has recently been the subject of amantadine use. Mechanism of action. Antiviral activity predominantly intervenes with the viral replication of amantadine, destroys the transmembrane domain of the viral M2 protein that inhibits infectious viral nucleic acid entry into the host cell. It is additionally going to inhibit the assembly of influenza A virus isolates from each of the subtypes that are H1N1, H2N2, and H3N2 during replication. The M2 protein of influenza B has a different structure because of which amantadine becomes ineffective. For the treatment of Parkinson's disease, according to many studies and research, amantadine works on the dopamine neurons. Amantadine is a weak non-competitive antagonist NMDA receptor which increases the release of dopamine and stops the reuptake of it. While amantadine might not have anticholinergic activity, bound anticholinergic side effects will clinically occur like dry mouth, retentivity, and constipation. There could be immunodulatory properties of amantadine, development of interleukin 2 that is damaged in patients with Parkinson's disease has been repaired. The levels of IL-2 were not consistent with active treatment, so the importance of these outcomes are still unclear. Parkinson's disease. Parkinsonism is a medical condition characterized by at least two of the two central characteristics: bradykinesia, that is slow and limited movement; rigidity, tremor resting, that is trembling; and postural balance dysfunction resulting in gait and fall damage. Idiopathic Parkinson's disease (PD), first identified in 1817 as paralysis agitans by James Parkinson, who is an English physician. The key signs and symptoms were presented by Dr. Parkinson. Researchers have investigated the cause and diagnosis of the disease for the next century and a half, identifying its spectrum of symptoms and its spread within the population and interpretations for its cure. While the effectiveness of amantadine compared to placebo, which is a substance or treatment which is designed to have no therapeutic value, it is done for the identification of motor dysfunction in PD and has additionally been tested throughout a lot of analysis. Most experiments were undertaken within the 1970s and resulted in faulty technique or low number of patients. Six randomized clinical studies that used amantadine as either mono or adjunctive medical aid in PD were known during a review in 2002. All the potential advantages of amantadine were documented. It was absolutely found that the accessible proof was incomplete to draw any concrete conclusions. Amantadine to treat dyskinesis in Parkinson's disease. In 1998, amantadine reported a 60% decrease within the prevalence of nervous disorder caused by endovenous levodopa by not modifying the anti-Parkinson impact of levodopa in an exceedingly double-blind placebo-controlled research study, which means a study in which neither the participants nor the experimenters know who is receiving any particular treatment. 18 patients were included within the trial and 4 withdrew because of adverse effects, particularly confusion and hallucinations. The anti-dyskinetic impact of amantadine was sustained over 1 year later in an exceedingly follow-up study that turned out to be 56%, though the study was of an uncommon layout and therefore the number of patients were restricted. While most studies have had methodological issues, the overall picture demonstrates that amantadine is effective for the short-term treatment of dyskinesis, although its long-term effectiveness is little understood and patients could become resistant to the drug. A 2003 review found that there was insufficient evidence to assess the efficacy of amantadine in treatment of levodopa-induced dyskinesis. Next, dose of amantadine in clinical studies. A daily dose of 200 mg or 300 mg of amantadine has been utilized in most analysis findings. Only 100 mg was utilized in one analysis and up to 400 was utilized in another. It is tough to work out if either higher doses have made a lot of side effects, whether there is no proof on whether or not a dose raise might enhance the long effectiveness of amantadine. Next, the side effects and adverse reactions. Withdrawal symptoms of amantadine most ordinarily livedo reticularis, that is skin discoloration, dizziness, eating disorder, and blurred vision appear to be mild and transient. This resulted in few withdrawals from patients. Confusion and hallucinations, however, is troublesome, particularly among older PD patients. In patients with renal disorder, harmful levels of amantadine may still occur because the drug is excreted within the urine. Brain disorder, acute delirium, and motor deterioration may result from the drawdown of amantadine. Three patients aged 73 on the average developed acute confusion, disorientation, and psychosis concerning stopping long amantadine medical aid. So, amantadine in other akinetic rigid disorders, which is defined as paucity and slowness of movement accompanied by muscle stiffness and resistance to passive movement. So, very limited data on the effectiveness of amantadine in other akinetic rigid disorders are usable and well-designed drug trials are required. Often, amantadine is used in the lack of a reaction to other therapies, particularly levodopa. Based on anecdotal evidence, patients may focus on improving with treatment and get worse with withdrawal, but it remains questionable whether amantadine generates accurate therapeutic benefit. In conclusion, I would like to say amantadine tends to intensify PD dyskinesis in the brief period, but how long such beneficial impacts are maintained is uncertain. It is possibly also mild effective for the motor symptoms of PD, although it is much less effective than levodopa. In individual with a diagnosis of confusion or hallucinations, amantadine should be interpreted cautiously. The lack of knowledge available for PD and other akinetic rigid diseases illustrates the need for this pharmacologically relevant drug to be more reliable in drug testing. Thank you.